Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members, initially about the COVID-19 pandemic, and now about pretty much anything and everything infectious disease and infection prevention related. So thank you for tuning in. For those of you in Arizona and anybody tuning in from outside, welcome, welcome, welcome. This is the week of May 13th, and it's been a couple weeks since I had the joy and fun of going on a National Geographic cruise to the Inside Passage up to Alaska. So lots and lots of animal, flora, and fauna sightings and great activities, but it's good to be back and back in the hot seat answering some fabulous questions. State of the world in terms of infectious diseases out there. Yes, indeed, SARS-CoV-2 is around, but it's quieter than it has been, although we still do get the sporadic positive patient, pediatrics at least, coming in with upper respiratory disease. Influenza A and B has slowed down both in Arizona and nationally, as has RSV, rhinoenterovirus, and a couple others as well. So as the respiratory virus season has been settling down, the gastroenteritis virus season, of course, continues to be present. So our dear friend, not norovirus, and its related diseases are definitely still around and making themselves quite well known. Group A strep continues to be a source of invasive disease, both from a respiratory, meaning pneumonia, empyema, disease possibilities, all the way up to, in some cases, toxic shock-like syndrome and invasive sepsis syndrome. So all those things are still out there, but nothing really is rising to the top of the heap in terms of being what we are seeing in the emergency departments. Some great questions, and again, since it's been a couple weeks, we have more than a couple of them, and we'll just start right off at the top. The first question is, should we be recommending the BCG vaccine to patients that live close to the Arizona/Mexico border and travel frequently to Mexico? So just as a bit of a backstory, the recommendation, first of all, in the United States, we do not routinely give BCG vaccination. And the reason, quite realistically, is it's not a highly effective vaccine. And also, we have access to very effective treatment of latent TB infection for those patients who are exposed and initially infected. We also, thankfully, both here in the United States and elsewhere in North America, have very, very low rates of drug-resistant tuberculosis. Not zero, because they are imported from elsewhere in the world, but overall, TB is a treatable infection and disease. And so in the States, we do not routinely give vaccine for it. In Mexico, however, vaccine is still routinely recommended and administered to babies. And the recommendation then in the States is that patients who are younger than 5 years of age and who will be traveling to a tuberculosis endemic area for longer than 4 weeks together, cumulative. So that is going to be not the casual visit across the border, but that patient who's actually going to be in country for more than 4 weeks. Those are patients who should receive a travel-associated BCG vaccine at least 3 months before the travel to that endemic country of origin. So by that recommendation, and by also what I've just shared with you about U.S. policy, the answer is no. We should not routinely be recommending BCG vaccine to our babies, our children less than 5, who are close to the border and who also travel back and forth frequently. Yeah, so that's the official. I think we certainly can individualize that if a family requests it and one has access to the BCG vaccine. It's quite reasonable to go ahead with that vaccination strategy. But in general, the recommendation is no. Related question, which substrain of BCG vaccine does Mexico use? Well, there are two choices, and the first is the BCG Mexico. By the way, all these are subvariants of the original BCG lineage, and they have been identified with some small mutational changes from the original lineage. Why one might choose one substrain of BCG vaccine versus another really depends on what is hosted or what is provided by that country, and it probably reflects what the country is seeing in terms of TB, mycobacterial disease. But honestly, when one does a head-to-head comparison of all the substrains, there is no individual substrain vaccine which performs any better or any less well than the others. So it really doesn't matter, quite honestly. But to the question, BCG Mexico and BCG Pasteur are the two substrains that have been in use in Mexico and can be found even today, depending on what part of Mexico one is getting vaccinated. Okay, continuing on with the theme of Mexico, the next question. Is Mexico considered high risk for measles, and should we be immunizing our 6 to 11-month-olds? Short answer is every country, of course, is having measles cases, outbreaks, clusters, whatever you wish to say, and Mexico is no exception. However, Mexico is no greater in its number of confirmed cases than is the United States. We're all right around the mid-hundreds or so. So currently, Mexico is not considered a high-risk or endemic country for measles. And actually, this sort of ties into the next question, which is that I read that the CDC recommends the MMR vaccine for infants 6 to 11 months, so earlier than the usual vaccine strategy, who are traveling internationally. But given the recent increase in measles cases throughout the United States, is it worth considering MMR vaccine for infants 6 to 11 months old who are flying domestically? So to sort of ask or answer both questions together, where are the high-risk countries? And those are actually almost all coming to us from the Middle East, such as Afghanistan, Pakistan, from India, and from Russia and the Russia Federation countries. So those countries that were formerly one of the Soviet republics, like Azerbaijan, are all considered to be high risk with high numbers of measles due to decreased measles vaccine rates. Now, you could certainly argue the United States, Mexico, elsewhere in North America, and also Central and South America suffer from the emerging same trend, decreasing MMR vaccine rates. And that is true, but still, at least today, our numbers are not super high. So, the recommendation for vaccination for international travel makes a whole lot of sense, even if one is not traveling to an international country with a high measles risk, such as the ones I just discussed, but anywhere else, just because international travel will involve a lot of crossover from travelers coming from some of those high-risk countries potentially. That risk is lower when you look at domestic flights, since most domestic flights are U.S. origin with a fewer number of international travelers. Not zero, the risk is certainly not zero. But right now, the recommendation for earlier than normal MMR vaccination for babies 6 to 11 months old is not active in general for the United States. If our numbers become higher, meaning the risk of endemicity in the United States becomes a real risk, then of course that recommendation will come through. And also in parts of our country, the United States, where there are current outbreaks. And I think perhaps the most strong one right now is in Chicago, related to housing for international immigrants. So exposures in areas with a current outbreak or a higher number of cases than the normal trend may drive a vaccine recommendation for 6 to 11 months old. Those of us who have been in Arizona back as far as 2008, remember in Pima County, we had quite an outbreak, and there was that vaccine strategy recommendation to immunize earlier. So that's a lot of words. Long story short, no, there is not a recommendation for domestic travel or United States routine vaccination with MMR prior to the usual strategy of 12 to 15 months of life. Okay, we were just firing right through these. Next question. I work in the newborn nursery as well as outpatient peds clinic with lots of newborns. With the new Red Book coming out, and actually it's out, and a new CMV algorithm for treatment, wondering if you recommend universal screening for congenital CMV in newborns and or moms in the nursery. Wow, great question. And I think first, just what does the new Red Book have in its treatment algorithm? Testing is still the same in terms of how and when to test a baby with suspected congenital CMV, and that would be by nucleic acid testing or PCR from the urine in the first 3 weeks of life. That's to more accurately define a baby who acquired CMV perinatally or congenitally versus the high risk of acquiring it postnatally. I mean, CMV is a very common disease in infants, children, and adults. So the testing algorithms have not changed. But in the Red Book now, they're table 3.4 on page 349, if you have the new 33rd edition of the Red Book, is now very clear that there is benefit for oral valganciclovir in several populations of babies with congenitally acquired CMV. The first population are those babies who are moderately to severely symptomatic at birth, or certainly in the first couple weeks of life. And those are babies, if one starts oral valganciclovir in the first 13 weeks of life and continue it for 6 months, there is a 20 to 40% improvement by 2 years of age in symptoms and risk of sensory neural hearing loss. And to be quite clear, our major treatment strategy is to reduce the risk or mitigate or improve that sensory neural hearing loss. CMV is the number one non-genetic cause of sensory neural hearing loss in the United States. So the treatment is truly aimed at improving that as an outcome. So those babies who are moderately to severely symptomatic at birth or even the first couple weeks of life deserve 6 months of oral valganciclovir with an improved outcome by aged 2 years. The other population who deserves treatment are those who are asymptomatic at birth but have isolated sensory neural hearing loss. So the baby who fails the initial hearing screen, and this gets into when one can start screening for CMV, should have targeted screening for CMV. And we'll talk about strategies in just a second. But those babies who are identified with primary isolated sensory neural hearing loss in the first 13 weeks of life, if one starts oral valganciclovir for 6 weeks, there is an improvement by age 2 years of that hearing loss and outcomes in general. So those are the two populations. Babies who are asymptomatic or mildly symptomatic, who have only 2 mild symptoms of CMV at birth, are not targeted for treatment because there has not been benefit shown, and also that population is very difficult to capture in a study, and thus it's not well studied. That is, if you care to look at the new Red Book, that is a brief summary of the treatment algorithm that the questioner is referring to. So, because we now have demonstrated benefit for treatment if one captures a baby with severe moderate disease or sensory neural hearing loss in the first 13 weeks of life, that would suggest benefit from universal screening. And of course, that makes a lot of sense. The challenge is, however, that universal screening is going to capture a whole bunch of babies who are not going to develop sensory neural hearing loss, who don't have disease, and who don't deserve treatment. So a necessary part of universal screening must be the physicians in that state, in the country, wherever you wish to talk about, who are quite comfortable and facile in making treatment decisions which are evidence-based and targeted for outcomes such as just discussed. And that involves a whole bunch of education. That involves, I think, a fair amount of workload for public health sites and for us as providers before we start to get those kind of data back. That said, Minnesota has enacted universal newborn CMV screening as part of its state screen, and Connecticut in 2025 will do so as well. Also, there are several parts of Canada, Ontario and Saskatchewan, who also have gone to universal screening and are studying their outcomes to see what the benefits might be. Too early to tell, at least not that I've seen published so far. So there are parts of the North America continent that are doing universal screening. On the other side, though, targeted screening, meaning those babies who fail their initial hearing screen or who develop evidence of hearing loss in the first 13 weeks of life, are then being specifically screened for CMV by PCR. And there are a fair number of states that currently do so. Arizona is not one of them. So those states that require both targeted newborn screening and education of pregnant women, and in case you're tuning in from one of these states, congratulations, that's awesome. So that's Illinois, Iowa, Kentucky, Maine, New York, Pennsylvania, Texas, and Utah. And then, in addition, Connecticut, Florida, Iowa, Kentucky, Louisiana, Texas, and Virginia also have a more broad recommendation that any newborn who fails any hearing screen to be tested for CMV. So that would be the targeted screening, which makes, I think, more sense because testing, getting a positive result in the first 13 weeks of life with hearing loss is going to drive a treatment recommendation. So universal screening, I think we're not quite there yet unless we can get a lot more education about whom and when to treat. But targeted screening makes a whole bunch of sense, and I would fully support that. All of that said, the otolaryngology associations have come out in full support of universal screening, and I certainly respect that as a recommendation as well. I would just hope that we can all educate ourselves, I think, rapidly about how and when and whom to treat with valganciclovir. So great question. This is certainly not a closed topic at all, and we'll keep it open and see what develops going forward. All right, last question. What is the current status of the CDC's consideration of data from the Johns Hopkins study, which just concluded October of last year, as to whether or not to preferentially recommend Vaxelis, which is a hexavalent combination vaccine, in case one is not up on vaccine names, in addition to the PVAX-Hib, for the primary series for American Indian and Native American children? Yeah, okay, so again, great question. So here, the study is the HIB-VAX study, coordinated through the Johns Hopkins College of Public Health, and studying Native American, American Indian children in several states and where there was a higher population with those patients. The vaccine itself, well, first let me step back a little bit further. What is the risk of Haemophilus influenza type B, and how is it different? Why are we even studying this specific population? Well, it is a higher risk, and it's an earlier risk for children who are American Indian, Native American. In fact, they have a 5-fold higher risk for and rate of invasive Haemophilus influenza type B disease compared to the general U.S. population. And they develop their peak of disease earlier. So they develop their peak of disease at 5 months of life. So you could argue, and that's the peak, by the way. The risk starts even as early as 2 months. So the peak of disease at 5 months means they may have only had 2 of their primary series of HIB vaccinations, whatever that product looks like. The median of disease, again, just carrying out the statistical assessment, median disease is at 14 months for Native American, American Indian children, which is sooner than it is for the rest of the U.S. population, which is 18 to 20 months. So yes, there is higher risk and earlier risk of invasive HIB disease in American Indian, Native American children, and so the need to vaccinate them successfully and effectively, of course, is robust. Vaxelis, this hexavalent combination vaccine, was licensed back in 2018, and it is one of the recommended vaccines that we all obviously can use for our primary series in all children. However, there was not a specific recommendation by the CDC for the American Indian, Native American population because the protection after the first dose was not known. Basically, outcomes, how much protection is there? We know that there's robust protection from the current isolated vaccine, that the PVAX-Hib, so specific to Haemophilus influenza type B, but sometimes combination vaccines require booster doses to achieve equivalency or non-inferiority to specific individual vaccines. So that had not yet been studied, and that's what the study has conducted. So the study concluded, this is true, its results have not been published yet, but they have been presented by Johns Hopkins and the CDC. And just, to cut a long story short, once again, the level of seroprotection and the identified criteria for non-inferiority were achieved by the combination Vaxelis vaccine when compared to the individual HIB vaccine. So yes, the combination vaccine is equivalent, does work. It certainly provides excellent, adequate protection. That has not yet been translated into a formal CDC or FDA or ACIP recommendation. But again, this is fairly recent data and has yet to be, I think, published and peer-reviewed. But when it does, then I think one will see Vaxelis included as a vaccine which can and should be used in those patients who are Native American, American Indian. The recommendation by the study is to actually have a preferential recommendation for that vaccine because it does achieve significantly high protective levels of protection against Haemophilus influenza type B, along with other encapsulated bacteria to which these children in this specific population are at risk. So there you go. So super, super cool. And again, a well-conducted study. They had excellent inclusion-exclusion criteria. I look forward to the actual publication of those results so that all of us can benefit from seeing, a really excellent focused epidemiologic survey. And just to reassure the questioner, no, one is not behind on staying up to date on such data, because even the usual pre-release journals are really cooling their jets a little bit from the COVID pandemic days, because a whole bunch of data was early released and found in subsequent assessment to not be successful or not actually be effective in terms of an evidence-based approach. So I think appropriately we're seeing fewer early release results published, which means then that the peer review process can and will take place, and what is published is adequate and excellent. So there you go. Those are the questions, and thank you once again for listening to ID Talk. Arizona AAP members can submit questions for future episodes too, and this is a new email, id@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, keep fighting the good fight, hang in there, take care of yourselves, and thank all of you for your service.